today, and welcome to our program entitled Get Ready for the Comprehensive Joint Replacement Program. The time is now. Before I turn the presentation over to our speakers, I'd like to go over a few housekeeping items with everyone. Today's program is approximately 1 hour, and it will be followed by a brief question and answer session. So we do encourage you to submit questions during the program. You can type those into the Q&A widget, which is open on the left-hand side of your screen. If you don't see the Q&A widget, you should be able to open it via the Q&A button at the bottom. Please type your question into the Q&A widget open on the left hand. We'll respond to those questions at the end of the program, assuming we have time. If we are running short on time, don't worry. We will have a snapshot of those questions, and we will be able to follow up with you individually following the event today. So please do remember to submit those. We will get to all questions at one point or another. The webcast console you are looking at can be completely customized, so you can resize or move any of the windows that you do have open currently, including maximizing the PowerPoint presentation on your screen. If you experience technical difficulties during the presentation, please visit the webcast help guide by clicking on the help button below the presentation window, which is designated with a question mark icon. A copy of today's presentation slides are available for download via the resource list widget open on the left-hand side of your screen. Additionally, Foley will apply for continuing legal education credit after this web conference. If you did not supply your state bar and license number upon registration, please email that information to me either currently during the presentation or shortly after. And my email address is ajones@foley.com, and my name is Allison Jones. So that's AJONES@foley.com. To be eligible for CLE, you will need to be logged into the On24 session for the entirety of today's program, and you will also need to answer a polling question during the program. Please note that certificates of attendance will be distributed to eligible participants via email approximately 8 weeks after today's conference. And as a final note, for those of you who are seeking Kansas, New York, and or New Jersey CLE credit, please note that you are required to complete the the attorney affirmation form in addition to answering the polling question during the program today. So that 5-digit course code that will be announced later on throughout the presentation, you should be able to fill that in on the attorney affirmation form. Once that form is filled out, you can email that to me. Again, that's Allison Jones at ajones@foley.com following the program. A link to the form was included in your confirmation email. A copy is also available in the resource list widget. And again, if you are unable to find those two sources, feel free to contact me directly, and I'll send you a copy of that attorney affirmation form. Thank you very much. And with that, I will turn the program over to our speakers today. We have Christopher Donovan and Fred Galfus from Foley and Lardner, and Dave Terry from Artois Health. Chris, over to you.
Thank you, Allison, and happy Friday, everybody. Welcome to the webcast. This is actually our 4th installment in our Bundled Payment Best Practices web conference series. We're very excited about it, and I think in our discussions before this session, we're definitely getting a sense that the interest and engagement in particularly in the CJR is accelerating as we come closer to the end of the year when there's actual downside risk associated with the program kicking in for hospitals. So this is a really interesting area, and I think one we're excited about, and we think we have a really interesting discussion for you today and a good panel. By way of background, I'm a partner here at Foley and Lardner. Been practicing many years, more than I care to admit. Cover the spectrum of providers. I have sort of a particular expertise in post-acute care, handling both compliance and M&A transactions as well as investments for private equity firms. I'm joined by my colleague Fred Galfus, who counsels health systems, hospitals, medical clinics, rehab agencies, nursing homes, and other providers. He also has many years of experience in healthcare acquisitions, integrated delivery system issues, managed care contracting, as well as defense of providers against government enforcement actions and medical staff issues. And finally, to round out our panel today is Dave Terry. Dave is the CEO and founder of Artois Health, one of the leading bundle payment providers and companies in the space. Dave has been working in care and risk management with healthcare providers really all along the continuum of care for over 20 years. He's worked within all types of reimbursement systems and has focused on bundle payment programs since Medicare first created a major demonstration in 2011. Dave is the CEO and co-founder of Artois Health, whose mission is to fix healthcare reform by designing and implementing market-leading bundle payment initiatives. He holds a BA in political science from Columbia and his master's from Harvard Business School. So with those introductions, really the format here is going to be as follows. It's pretty straightforward, and we hope we can leave adequate room for questions as we have in the past sessions. I'm going to give a little bit of a table set or overview of the CJR just to bring everybody's familiarity up to speed again with the basics of the program. I'm going to be followed in that presentation by Fred Gaiofas, my partner, who's going to address the programmatic waivers under the CJR and the fraud and abuse waivers under the program. Following that, Dave is going to engage in a discussion about how to actually assess, implement, and develop a strategy for dealing with CJR, focusing on some of the products that Archway has, some of the data analytics, some of the prioritization that hospitals should be engaging in terms of the first steps associated with evolving a CJR program, and then finally we're going to engage in a Q&A at the end. And as Allison pointed out, you can submit questions in writing right on the screen there. So without further ado, here we go. And as everybody knows, we're talking about CJR, and we're not going to address cardio. There's a new cardio bundle out, as everybody knows, but I think it's our feeling here at Foley, and I know Archway shares this, is that we're at an inflection point, I think, in many ways in terms of bundle payments. Everybody's familiar with the CMS proclamations about having 70, 80, 90% of all their fee-for-service payments attributable to some type of alternative payment methodology, many of which will be bundle payment. But I think this is really a tipping point in terms of hospitals and providers really engaging in this area to succeed, and yes, having to invest some time, effort, and capital and resources to be successful in this area. So we're hoping this session is going to highlight some of the strategies to do that and some of the compliance issues, at least on the legal side of doing that. So without further ado, I'm going to just start advancing the slides here and engage, just give that overview that I just discussed. So the CJR is a program that focuses on acute care hospitals in certain selected geographic areas that are identified in the CJR regulations. It essentially makes the hospital the hub and spokes for the financial exposure on the episode of care by making it the party that's responsible for not only the inpatient portion of the procedure for surgical hip and femur replacement and as proposed fracture in the future, but it makes them responsible for essentially all Part A and B services during the entire episode of care, which is defined under the regulations as the admission of the individual to the hospital and concludes 90 days after discharge from the hospital. So that's the risk component, I think, that's going to generate the collaboration effort that we anticipate happening. So in a nutshell, it includes all Part A and B services for that 90-day period. It's mandatory in roughly 800 hospitals in 67 MSAs. I think as I said off the top, even though the program began April 1, 2016, the downside risk associated with the program doesn't commence until January 1, 2017. And, that's when we believe hospitals and collaborators, PGPs, nursing homes, et cetera, will want to have their collaboration agreements in place and their strategies well locked down such that they're in a position to participate in Gainsharing. It's a 5-year program. And as everybody probably knows, it's a retrospective two-sided risk model with hospitals bearing the financial risk. So it's in some ways similar to the the bundle payment programs, the voluntary BPCI programs, in the sense that the providers and suppliers continue to be billing Medicare based on FFS, and at the end of every year there's a reconciliation comparing actual episode spending compared with the episode target price, which I'll get to in a minute as to how that's calculated. Generally speaking, the admitting hospital or the anchor hospital receives benefit if the costs are below the target, and it bears the risk if the costs exceed the target. As with the cardio bundle, there's stop loss and stop gain provisions in the CJR. So for years 1 and 2, the downside loss is capped at 5%. It moves to 10% in year 3, and it's capped at 20% in years 4 and 5. The stop loss is virtually, the mirror of that, with the exception that there's no responsibility for any losses in 2016, as I've discussed. So, this has been a period during which we believe most people are getting their strategy together, trying to put their post-acute network together, having discussions with their referring orthopedic surgeons and practice groups, identifying where their strengths and weaknesses are, and really trying to put their strategy together. In terms of the target pricing, each hospital has its own episode target prices set by CMS based on 3 years of historical data. And the idea here was to really transition and phase in hospitals into this bundle payment program rather than do it, in sort of a dramatic fashion in 1 year. So basically, there's a 3-year transition or 5-year transition process, I should say, over the 5 years by which the hospital transitions for the purposes of its target pricing from in the first year where 2/3 of the target price is based on the hospital's historic costs and 1/3 are regional, to in the 3rd year sort of flipping that ratio such that only 1/3 of the target is attributable to the historic hospital costs and 2/3 are regional. And in the 4th and 5th years, the target pricing being 100% regional. So obviously, and Dave, I'm sure will talk about this, identifying, as a hospital where you are on regional pricing, whether you're above or below it, is a data point that, you'd want to identify early on to see, where you are on this, in the process here, and from a timing standpoint, how quickly you have to move, to come into compliance with regional pricing. On top of this, before the savings kick in, the terminology, if you're getting money from CMS, they're called reconciliation payments. If you're paying money to CMS, they're called alignment payments. But to get these reconciliation payments, the hospital and their ability to share them with their Gainsharing collaborators are subject to a 3% deductible or 3% discount to serve as Medicare's savings. And that 3%, and Dave will talk about this, I'm sure as well, is subject to various quality metrics that are really a composite quality score that are a function of a number of things. Complication rate, which is attributable to 50% of the quality score, consumer surveys, which are 40%, and data submission, which are 10%. This composite data on quality can serve to reduce this 3% discount from 3% down to 1%, depending on where the hospital is in the quality metric compared to peers in its group. So it's a way for not only is there gain sharing based on the target pricing, there's additional incentives based on quality composite scoring when comparing the hospital score to those of its peers. There's also, I should mention, if there's a sort of a low episode carve-out for hospitals that have less than 20 episodes in a 3-year period, those hospitals actually go 100% to regional pricing right away. Fred, do you want to take it from here on the overview?
Sure. Thanks, Chris, and welcome, everybody. As Chris mentioned, in the CJR program, the hospital is at the core. The hospital has the risk for the whole episode, even though it may only be the provider of certain services and is likely to be only the provider of certain services. That makes the hospital responsible for non-hospital providers. So there really is a need to focus, and given that there's downside risk, the hospitals really, it's in the hospital's interest to ensure that the other providers who are treating a patient during the episode are managing their care in appropriate fashion, doing what's necessary to hit the quality standards, and also being efficient in how they deliver their care. There is an ability for hospitals to engage these other providers that treat the patients in a hospital in an episode, and to share payments, which incents them to perform appropriately. They can also share the downside, the alignment payment, as you will. So putting together care redesign programs and getting other providers that treat patients on board will be critical, particularly for the hospitals that may be above the regional averages, or they'll may well own money back to CMS at the end of the episode or at the end of the year. So there are what's called collaborator agreements that the hospital may enter into with others that are treating patients during the episode. As we'll talk in a minute, the requirements for a collaborator agreement are extensive. I think there are 22 requirements that are spelled out that need to be included in a collaborator agreement, or which you have to be aware of as you move into a collaborator agreement. And you have to have a collaborator agreement if you're going to share gains or share the alignment payments. The hospital is obligated under the regulations to keep 50% of the downside risk. It can lay off the other 50% of an obligation to repay CMS to others who sign collaborator agreements, but it must keep 25% of the risk. And no one collaborator can be responsible for more than 25% of the downside risk. There also is a limitation on physicians. They're limited to receiving as gain-sharing payments 50% of the total Medicare-approved amounts under the physician fee schedule. I think the concern here is that hospitals who like to reward referring physicians will use the upside payments as a way to reward physicians, so they put a cap on it. And let's just move on. The program does have some programmatic waivers that we've seen in other CMS alternative payment programs that are designed to permit more coordination and to help realize some savings. One of the programmatic waivers is a waiver of the 3-day inpatient stay before a SNF admission, but that is only applicable if the SNF to which the patient is admitted has a 3-star rating from CMS on the quality side. Similarly, can be for post-discharge home visits. There's a waiver of the Incident 2 direct supervision for physician service requirement. That is not a requirement under the CJR program. And for global surgeries that may also be separately billed for up to 9 home visits during an episode. There's also a waiver of the telehealth geographic site requirements to promote the use of telehealth in CJR episodes. And there also is an easing of the requirement, at least I believe it's an easing, of the requirement of preferred providers in discharge planning. As you know, in discharge planning, hospitals have been limited in their ability to really steer to selected discharge to home care agencies and SNFs. The requirements under the CJR are that you can have a preferred provider, a post-acute preferred provider, and they can have collaborator agreements. You need to mention to the patient that you have a collaborator agreement. You must give the patient a list of the all the available providers, and you must honor any expressed patient or family choice on who to utilize. But there is some language about preferred providers, and they can be incented with collaborator agreements. As I mentioned earlier, these collaborator agreements or sharing agreements are ways for the hospital to involve and incentivize other providers in an episode to get on board and get on board with the care redesign plan and be efficient and ensure they provide quality services. So the opportunities really lie in aligning other providers for furnishing efficient services. Hospitals have been operating under the DRG for many years, and one would think that they've been incentivized and have been efficient in reducing the cost of care that's included that's reimbursed as part of the DRG, so that the opportunities probably lie more in the post-acute environment, the post-hospitalization aspect of an episode. And recall, it goes 90 days post-episode. So those will be the opportunities to really align with the home care providers and the SNFs and the LTACs and the other post-acute providers to focus on reducing cost. It's really critical, and I know Dave will go into this in much greater detail, but to analyze the cost of care furnished in an episode, in a typical episode, who's furnishing the care, and how you attack each of those components in an efficient and quality manner if you want to save money and not have an obligation to repay CMS. So there are opportunities for physician gain sharing under the waivers, the fraud and abuse waivers that we'll talk about. Prior to CJR, as I'm sure all will recall, there were some limitations initially on physician gain sharing, paying physicians to help drive down DRG costs, or costs that's covered by a DRG. And in the end, CMS and OIG did provide some guidance as to how you would go about appropriate gain sharing in those contexts. Under the CJR, there's much more flexibility in physician gain sharing than in than we've seen without the CJR. Again, post-acute services will be a key focus of opportunities to reduce care, to reduce the cost of care. In the BPCI, the initial results have been that the places where cost has been reduced and effectively has been the reduction of hospital readmissions and the provision of more home care as opposed to SNF care. Again, as I mentioned previously, these sharing agreements, collaborator agreements, have to be in writing. It's really important to line them up against what's required in the regulations because they're very extensive. They also, one of the conditions is that you cannot add additional criteria to the collaborator agreements beyond what's in the regulations. And you also have to, the criteria for sharing, you both in selection of who your preferred providers or your collaborators are and how you pay them needs to be based on quality. You have to have quality criteria in the selection process, written quality criteria for selecting your other providers that enter collaboration agreements with you. PGDs have special rules, and it's also critical to tie provider compliance in the CJR, in the collaborator agreement. There are some expanded fraud and abuse waivers available for the CJR. Unlike the waivers available for the Medicare Shared Savings Program, these waivers are very, I think, quite tight. They have specific standards and criteria that should be consulted to make sure you comply with them. And they really aren't self-effectuating. You have to have a collaborator agreement in place that complies with the regulations, and you're limited only to paying gain-sharing payments, which is really the reconciliation payments received from CMS, as well as certain specified internal cost savings that are generated. So those are the only payments that are covered in the first waiver, the waiver for distribution of gain-sharing payments and alignment payments. And you really cannot, there's a requirement that you not add additional conditions and that you meet quality criteria to qualify for as part of the standards for qualification for the waiver. There's a second waiver, which is very similar to the first, for distribution payments from a physician group practice to collaboration agents. Again, specific details on what you have to do to comply with that, and I think they'll be important if you're going to share payments or share risk with other providers. You're going to want to comply with these waivers. I think they'll be important. If you don't comply with them, that it's not necessarily a problem, and there may be other ways to be consistent with Stark and/or the anti-kickback statute. It's just a much tougher pathway and road. Finally, there's also a waiver for patient engagement incentives provided by participant hospitals to Medicare beneficiaries. These are for such things as adherence to a care plan that's developed. There are transportation things you can do. You can provide in-kind incentives to directly to Medicare beneficiaries. They need to be in kind. They can't be in the form of cash. But there's some opportunities there if you're having patients that are struggling to comply with the care plan and the adherence measures that you're looking forward, that you need for that patient to comply with in order to really deliver on the efficiency. At this point, I will turn the slides over to Dave Terry to talk about it.
Great. Thanks, Fred. That was helpful, and thanks, Chris and Fred and the folks at Foley Lardner for the invitation to participate today. Happy to be here this afternoon. So I'm Dave Terry, the CEO of Artois Health, and I'm going to go through a brief overview of Artois, who we are and what we do. Kind of give an update on the bundle payment market because it is growing and changing pretty rapidly, driven in large part by Medicare, but increasing activity we're seeing in the commercial market. And then we've developed in the programs that we're helping to support a three-phased process for CJR program management, and I'll walk through that. So just a bit about Archway. As Chris said in the beginning, our mission is to fix healthcare through payment reform. We do that by focusing on bundle payment programs, working with providers and payers to build and manage and succeed within bundle payment programs. Bundle payment is all we do, 100% focused on that. We are active in all of the current Medicare programs, the BPCI program, which was first announced by CMS in 2011, the CJR program, which started in April, the Oncology Care Model program that started in July, and we're involved in making public comment or making comments during the public comment period to the episode payment model, which CMS announced in July will start July 1st of next year. That's mainly the cardiology bundles, mandatory cardiology bundles that they've created. We're also working with commercial plans and employers to create and implement bundles in that market. I think we try to differentiate ourselves in this market. I know that everyone is being bombarded by folks who want to provide services to providers who are in these programs. There's a ton of activity out there. We do try to differentiate ourselves in a couple of ways. One, we've built a comprehensive program. We try to take a holistic approach to these initiatives. We think there are a number of aspects that are required to be successful. One is just advisory services and coaching services to help providers understand how these programs work, and we spend a lot of time doing that. We understand the rules and the strategy, so we do a lot with that. We do a ton with claims data analytics, and I'll show that show a bunch of kind of our perspective on that here. And then we get involved in patient tracking and the care management process and the risk management process. I think we're unique in that we take this holistic approach, and we're working with all these programs. We've got dozens of customers we're working with, and represent hundreds of providers. We've got great results. Everyone we're working with is seeing improvement in their processes, improved outcomes, and their earning savings in their programs, and in some cases, significant savings. And we've been in these initiatives since they were initiated. When CMS first got started with BPCI in 2011, our team was involved in the very beginning, and so we've been in it for a long time, and we're 100% committed to this market. I mentioned our results. So this is representative of the results we're seeing in our orthopedic bundles. So we're doing all kinds of bundles in BPCI and in oncology, but specific to orthopedics. We're seeing great improvement in patient satisfaction, great compliance with our process, reduction in readmissions, and savings ranging from 9% to 17% of target price with the orthopedic organizations we're working with. In some cases, those are hospitals initiating ortho bundles, and in some cases, those are physician groups initiating ortho bundles, ranging from $2,000 to $4,700 in savings per case across a number of different providers and provider types. And I would say what's driving that is this is a relatively new slide that we created, and kind of represents what we see as the 4 key elements for a really effective bundle payment program. One is sort of a prerequisite, and that's just the presence of a contract that creates a bundle payment program. Medicare obviously has now created a bunch of contracts in DPCI and CJR and the oncology model. Obviously having a contract that changes the incentives and creates more accountability and more opportunity for the episode initiating provider to do well, that's the first piece. The second piece is really good data analytics to understand what your current performance is, how that compares to others in the market, where the costs are, and where the opportunities for improvement are, as well as where the risks might be. The third piece is focused care management. And so in these programs, we get to focus very acutely on a specific type of patient population and a specific condition, and gearing the discharge planning team, the care management team, the hospitalists to really be engaged with that population and focused on those patients who need the most services. Frankly, we like to let folks who are doing well continue to do well without a lot of intervention, but focus on those folks who are off track and help them get back on track and get home as quickly and safely as possible, get ambulating as quickly as possible, and hopefully avoiding readmissions and complications. If those 3 pieces are in place, and particularly if the specialists are engaged, in this case the orthopedic surgeons, we're starting to see a ton of innovation. And that's the most exciting part for us as we transition away from fee-for-service. And we've got more accountable contracts, great data, good care management infrastructure. The doctors and the providers start to think just a lot differently about how to deliver better care for their patients over a 90-day period. And in orthopedics, we're seeing innovations like pre-surgical home visits, changing in the way how the conversations happen with the patients pre-surgery, better engagement between the surgeons and the folks who are running the joint class, really even getting into very specific clinical areas around surgical technique, anterior versus posterior surgical technique for joint replacement, how quickly patients ambulate, what the PT strategy is, where patients go post-discharge, what the timing is, how long they stay in the hospital, how long they stay in a SNF if they go to a SNF, which home care companies they use, and then what the tracking process looks like post-discharge, with which PT companies they use. So really lots of different changes around thinking about what the best path is, and that's happening not just through care management, but through really effective engagement with the doctors who understand these diseases and these conditions better than anybody else, in collaboration with the hospitals and the post-acute providers. So this is, as you can probably tell, this is my favorite slide, because this is where kind of the fun happens and where we really see a lot of improvement and a lot of change. Just a bit around the market. So our view, frankly, is bundle payment has transitioned really from a niche issue and a niche payment model to now a much bigger strategic area, strategic priority for providers for hospitals and physicians and providers of all types. So BPCI is the first program. There are about 1,500 providers in that program. our estimates and discussions with Medicare and looking at the information, that's about a $10 billion market right now in terms of total spend. CJR, there are 767 hospitals across the country in that program. It's about a $4 billion market. Oncology care model, there are 196 oncology organizations participating in that as of July 1st. And then the episode payment model, the cardiac program, it starts next year. There will be about 1,200 hospitals in 98 markets participating in that. CMS announced that's about a $6 billion program that they estimate. And then CMS also announced in July that in early 2018 they'll be rolling out what we call BPCI 2.0, essentially the next iteration of the BPCI program. It will be a voluntary program. It will have physician-initiated bundles as an option, probably hospital-initiated as well, but definitely physician-initiated. They want to create opportunities for doctors to participate in advanced APMs, for specialists to have advanced APMs to participate in MACRA, and that will be rolling out. And we expect the rules to come out for BPCI 2.0 in the first half of next year, probably first quarter of 2017, with a targeted start of the first half of 2018. And then in the commercial market, a year ago we were seeing very little activity in the commercial market, and we were talking to a lot of plans, and it wasn't really kind of getting much traction. We're now seeing a lot more activity, I think, for two reasons. One, CMS continues to push on this, and two, employers are starting to ask for it, and employers in some cases are starting to do it. We know GE is doing a lot. We know Lowe's and Walmart and some others are doing a lot. As the employers start to do it, the payers seem to be feeling more pressure to come up with a solution for their employer customers, and we're definitely seeing a lot more of that type of activity. So, our view is this is, just continuing to grow, clearly not going away, and it's going to be an increasing part about how providers get paid, and an increasingly important strategic issue for providers to think through and to understand. So back to CJR, we have a number of providers we're working with who are in the CJR program, and as I mentioned, we've been working in joint replacement and BPCI for a long time now. So we've developed a three-phase process for helping providers succeed within CJR. And so program preparation, program design, and program implementation. I know many of you on the call today are in various stages. We just went live in April, so some folks have been very proactive and have dived in and are well underway, and maybe deep into phase 3. We also see others who have been waiting longer, just because, as Chris said, downside risk doesn't start till next year. Many providers are already kind of in the money, given the way the pricing has been developed. It hasn't been a huge priority. So I know there's some mix of where folks are in this process, but I'll go through it a bit over the next set of slides. But phase 1, the goal for phase 1 is to dive into the data and really identify 2 or 3 priority areas to focus on in the first couple quarters of operations. We see the mistake we see sometimes that providers make is trying to do everything at once and just trying to boil the ocean and get everything done right off the bat. And there's a lot to do, but also there can be a fair amount of opportunity just by picking a couple areas to start, doing those really, really well, and then once those are kind of going smoothly, picking a few other areas to focus on. So phase 1 is really mostly about doing that and using the data to help guide that. So with that in mind, we spend a lot of time diving into the data. We've got a great claims data analytics team here that's been doing this for a long time. This is just an example of a chart. Many of you have probably seen similar charts like this, but understanding where the costs are going by type of bundle within the CJR program. There are 4 different bundle definitions in the program. In our experience, about 90, usually 90+% of the volume is going to be an elective 470s. It's an elective joint replacement without comorbidities and complications. And then understanding how much of the cost for for those patients is in the acute, the post-acute with the physicians, inpatient rehab facilities, SNFs, home health, those types of things. And then once that's understood, doing some benchmarking around where those costs are, where you stand, as a hospital, or your system stands relative to your pricing and others in the market. So this is just looking at the controllable costs. We've stripped out the DRG payment. There's opportunity in the inpatient side. Generally, we focus first on the post-acute opportunities, as Fred said. So this is looking at post-acute, what the costs are and how that compares to the hospital's price and to the others in their marketplace. So this is a real example. This is an interesting situation. So this hospital, their costs are about $16,000 on the controllable side. Their price is about $14,000. So they're at risk of losing a lot of money once the downside kicks in. That's the bad news. The good news is there are other providers in their market that are providing this service. This is elective 470s for up to $4,000. I'm sorry, up to $6,000 almost lower cost than what they're doing. So there seems to be a lot of opportunity for improvement here. I won't say definitively that there is. I mean, the data is only half the story or part of the story. We need to dig into this more. But it's a good starting point to say, you know, we need to do something because we've got some real risk of losses. But if we're successful, we have a lot of opportunity to do well in this program if we can start putting some programs and some ideas in place. You know, once we have sort of that level of information, we really want to drill more deeply into what's driving this. So this is a look at all the physicians, all the surgeons in a hospital that perform joint surgery and looking at their total cost of care on average, comparing that to the price for the hospital and understanding where those costs are going. So if we look at the top physician here, Dr. D, obviously very high cost physician. We want to dig into why, what's going on. These are not fractures, so this is not like he's caring for all emergency patients. This is, again, elective 470s. Clearly, the red piece here is skilled nursing facility. He's a very high utilizer of skilled nursing facility services. The purple is readmissions. He's also a relatively high number of readmissions. The other piece, though, is he's relatively low volume. It's only doing 19 cases. So, you know, some sort of discussion or understanding of what's going on with Dr. D and sort of thinking about a strategy specific to that physician would be, I think, important here. Dr. F is also an issue, a different kind of issue. You know, pretty high volume, 129 cases, but also pretty high cost, very high SNF utilization. So strategies obviously differ depending on the situation, but wanting to understand what your performance looks like by surgeon. We are strong advocates of gain sharing, and Fred outlined kind of how that works. We're strong advocates of gain sharing with surgeons in a strategic way. We wouldn't advocate necessarily every surgeon, but with select surgeons in a strategic way to align incentives with the health system and align incentives for improvement and for good performance in these programs. We think that's a very effective strategy. I'll also say, you know, Fred outlined the rules for how gain sharing works in CJR. The rules in the EPM model are a little bit different than how they work in CJR, and it does seem like CMS is moving towards creating more opportunity for broader gain sharing with certain types of physician groups. So I think there's more to come on that out of the EPM process, but it creates more opportunity for better alignment and engagement with the surgeons, which I can't emphasize enough is, I think, sort of one of the most important things to do in these programs to get that specialist innovation and collaboration going. We also spent a fair amount of time, this is a busy slide, but we also spent a fair amount of time looking at similar data for your post-acute providers. So this is looking at episodic costs for all the SNFs in a particular market. So we like to sort of array all the SNFs that you may, and all the home health agencies that you may be sending patients to, understand what their costs are on an episodic level. So, you know, when you send a patient there, what's the 90-day cost for that patient? That includes the SNF length of stay, any readmissions that are happening to that patient, either directly from the SNF or after they leave the SNF. Same thing for home health. And we use this to start establishing those preferred relationships that Fred talked about, and looking for who are already strong performers, and then also looking for who, among those strong performers, who's eager to get better, and who's eager to collaborate with us to continue to get better, because there's certainly opportunity. Even the best performers on this slide can get better. We're definitely seeing that. it's important not to just think about cost. Obviously, we want to think about quality. As Fred said, there's requirements. Your preferred collaborators need to be 3-star providers. We want to understand what the star ratings is, and not just the overall star rating, but how it breaks down across these various metrics, quality, staffing, survey, the things that CMS looks at when they create the star ratings. So that's important. The last slide here, I'm not going to get into the details. Chris talked about this, but there is a quality aspect to the way the CJR pricing is established, and it's kind of a complex composite scoring that CMS does. This is more important for some providers, and it's less important for other providers, frankly. And I don't want to say that the quality isn't important, but the scoring in and of itself, the way the scoring works, this could be economically have a big impact for providers who aren't doing very well on the quality side, and should be a big focus because it can have a significant impact. And for providers who are already doing okay to pretty well, it won't have a big financial impact. And so understanding how this works and where you sit today, we can figure out where a provider sits today based on publicly available information. But you want to know kind of where you rank and what the impact would be for you, given the way the scoring methodology works, and we've done a lot of that type of work. Phase 2, program design. I'm going to go through this pretty quickly. But once we have the data and understand what those 2 or 3 areas of focus are, a couple things that we try to help providers with. One is creating a really good team. Another mistake we sometimes see folks make is there's like 4 or 5 teams that are participating in kind of implementing these programs. We would much prefer to see one really good team that includes people from the joint class, people from case management, people from the orthopedic medical staff, starting to think about Gainsharing, starting to think about preferred provider networks. But a theme of kind of how we think about this is focus. Focus on what the priorities are and focus on who's participating in the process. Gainsharing, we've done this a bunch. Foley's done this a bunch. We see there's a handful of principles that we like to keep it simple, like keep it focused on high volume surgeons, at least to start. Keep the rules pretty simple. Make sure that it's folks who can actually have an influence on changing things and making things better. We don't really recommend Gainsharing, at least initially, with post-acute providers. We recommend collaborative relationships with them, preferred provider networks. We don't recommend Gainsharing there, but we do really like to get involved with Gainsharing with the surgeons. Skip that one. So the end of phase 2 is really kind of a pretty detailed work plan on those 2 or 3 priorities that we've identified. What do we want to focus on, and how do we want to make progress against those things? And then phase 3 is really what we spend most of our time doing, frankly. Paradoxically, I'm probably going to spend at least amount of my time in this presentation on phase 3, but this is implementation. And on the implementation side, what we really like to see is a very clear and simple care model design process for how these patients are engaged and managed in the program, tracking the patients as they move along the continuum of care, tracking their health status and getting the care management team engaged in that process, and tracking the financial performance. You get new data from CMS and CJR every quarter. We get it every month in BPCI. As soon as we get that data, we make it available to the finance team on a web platform so people can see how they're doing. So in terms of care management, obviously providers need to have their own care management process and feel comfortable with that. We've got a simple process that we've plugged into many of the folks we're working with. We call it the ENACT process: identify, notify, assess, care plan, and track. And it's working at dozens of provider organizations today, and it's very, very simple. But there are, we try to boil it down to the essential 5 steps. Part of that process, the track process, this is a dashboard that is populated by our CareLink tool that is really targeted at the care management team, so the care managers can identify all the patients who are in a bundle program, CJR, BPCI, whichever they're managing, and they can see who's on track and who's off track. So in this case, there's a red flag next to Hendrick's name. Hendrick's off track. So we need to have some sort of intervention or discussion about Hendrick to see what we can do to get him back on track. Everyone else is doing fine. So our focus is really the kind of 80-20 rule, focus on the 20% of patients or so who are off track and let the ones who are on track continue to make progress with the goal of trying to avoid complications and readmissions. And then we augment that with tracking of the financial performance. So this is an example of a screenshot from our Artois Analytics dashboard where we can see every time we get new data, we can see what our performance is by bundle type and how that breaks down by cost, SNF, home health, physician, et cetera. We can also see performance by physician. We can see performance by post-acute provider. We can do mock reconciliations. It's sort of this is more oriented toward the finance team and helping them stay on top of what performance looks like and where they may need to kind of dive into either to drive improvement or to realize more of the opportunities that might be out there. With that, I know I went through that very, very fast, but I wanted to leave some time for Q&A. I think, Allison, I'm going to hand it back to you, and we can dig into the Q&A.
Great. Thank you, Dave. So now I think it's a good time to break really quickly for today's polling question, which is meant for those who are seeking continuing legal education for today's program. So at this time, I'm going to read aloud the CLE course code. If you are requesting CLE credit for today's presentation, please enter the 5-digit code that I'm about to read into the polling question that will appear on your screen shortly. And then please be sure to press the submit button once you do enter that code so that we can track your answers. I will read the course code twice aloud. It is a combination of letters and numbers, so please pay close attention. And then the polling question slide on your screen will remain open briefly for about a minute or two to allow you time to submit your answer. As a reminder, if you are in Kansas, New York, and or New Jersey seeking credit, in addition to the polling question I'm about to read, you will also need to complete the attorney affirmation form and return it to me immediately following the program. Again, that copy of that form is available in your confirmation email as well as in the resource kit, or you are welcome to email me separately a copy. Okay, so at this time, I'm going to read the course code aloud. The course code is the number 4, followed by the letters W as in William, O as in ocean, V as in Victor, Z as in 0. I'll repeat that code once more. Again, it is the number 4, followed by the letters W as in William, O as in ocean, V as in Victor, Z as in 0. If for some reason you have trouble seeing the polling question on your screen, you are also welcome to enter that 5-digit code into the Q&A module. We will receive a report readout in that way as well. So again, now if you are seeking CLE credit for this session, please do complete the polling question now or submit your response via the Q&A module if you need to. We'll leave the poll open for another minute to give you guys time to submit your answer, and then we'll continue with the program. Okay, at this time the poll is now closed. If for some reason you are unable to enter the question into the poll question slide, again, please be sure to enter that code into the Q&A widget, and I'll pull the response from there. So now I would like to turn the program back over to our speakers for the Q&A portion of the program. So Chris, if you would like to take it from here.
Thanks, Allison. And Dave and Fred, thank you very much. I thought that was really an excellent overview of the fraud and abuse waivers, and Dave really breaking it down. I can see both the opportunities and the challenges, I guess, for this program for hospitals. But we have an enormous number of questions here that have come in, which I guess is a good sign or maybe a bad sign, but I think it's good we're having a discussion on this. So in the next few minutes, because we don't have a lot of time, I'm going to attempt to kind of consolidate some of these. So if you hear pieces of your question in the question as I rephrase it, it means I'm trying to answer a couple of questions at once. But one question was, what are the clearest opportunities to reduce the cost of the CJR episode? And another question, which is sort of, I think, tied to that is, do you have any legal issues with targeting high-volume surgeons versus offering gain sharing to all surgeons? And David, it kind of reminded me of that slide. I was going to say something where you had that high-cost, low-volume admitter, and at the top of your screen, and then a higher volume, lower cost physicians at the very bottom there. And the thought occurred to me, what's a hospital to do? Should they go after the high-cost, low-volume admitter as a strategy matter, or just focus on some of its high performers from a cost standpoint and not focus on them? And we actually looked at this. Somebody asked the same question in one of the other sessions, and what the commentary in the regs say is that there's no requirement that a hospital engage every orthopedic practice or every orthopedic physician in gain sharing. So there was some commentary and questioning about that they thought every physician had to be offered sort of the same opportunity. And I think the feedback that CMS gave was there may be different types of physicians or different types of post-acute providers that present unique skills. And my view of it is that there really isn't a requirement that you engage every single practice group in exactly the same or similar way. There is a requirement that in connection with your gain sharing, however, that you select your gain sharing partners or collaborators in accordance with a set of quality metrics that is adopted by the governing board of the hospital, and the same applies to post-acute providers. So there has to be some objectivity to it, but it's not to the point where it's mandatory. So that's my initial feedback. Fred and Dave, I don't know if you have any comments to add to that.
Yeah, Chris, this is Dave. So I was going to say part of what you just said, which is, my understanding is, and I'm glad to hear you support it, is that there's no requirement to share with all the surgeons or to create an equal program or anything like that. Obviously things can get political quickly, and so every situation is a little bit different. All the factors need to be considered. Also, looking at that list that I had up there of all those doctors, some of them will be in, many of them will be in, a handful of groups, and so doing something at the group level is, can be an interesting way to create alignment. If the group's going to lose money because Dr. D is just, not doing a great job with these patients, and making it a group responsibility is a strategy that we've seen be effective. I'll make an editorial comment. If someone's doing a dozen or a couple dozen joint surgeries a year, but they're primarily a shoulder surgery, they shouldn't be doing joints anymore. They just really shouldn't be doing it. And we're starting to see those conversations happen among groups who are taking risks in these programs because they finally have an economic reason, frankly, to get the low volume partners who aren't as good at it as their high volume partners to stop. And so, that doesn't happen overnight, and it can be complicated and political for a hospital to have those conversations. But from a quality perspective, we are seeing that happen, and we think that's a good thing. And fortunately or unfortunately, it's driven by the economics, but we are seeing those types of things happen, and that's positive. And there are a variety of strategies to take that on. And again, I don't want to create the impression it's easy, but there's different ways to think about that and do that.
Yeah, I would just mention that the regulations do specify that the selection criteria cannot be based directly or indirectly on the volume or value of referrals or business otherwise generated. So that would be, again, a word of caution. And you wouldn't want selection criteria that really say we're only going to pick the high volume referrers to the hospital.
Yeah, that's fair.
Good point.
I know we're out of time. So one other question, Chris, I wanted to address, a question around does the dashboard have quality metrics as well as financial metrics? The answer is yes. And I just showed a couple of the dashboards that we have, but what's driving a lot of the information we're getting in our CareLink tool is information about the health status and the progress the patient's making on a health status basis. And so that information is available. And it also includes for CJR the ability to include patient-reported outcomes as well as financial aspects of what's as the patient progresses upon.
Right. And actually, Fred, just going back to your comment on the docs, and this applies to the post-acute providers. In all cases with these collaborators, the selection of the collaborators as well as the methodology for the gain sharing payment has to be based on, predetermined objective criteria that are in some way, at least in part, tied to quality. So I think, and that's tied into what you're saying. It can't be solely based on volume or value of referrals or, even primarily. So I think, rolling this out from a hospital standpoint, in addition to getting some data analytics like Dave's firm can provide, I think it has to start with, those kind of criteria, because those objective criteria that are going to determine collaborator selection as well as gain sharing payments have to be, determined upfront, adopted by the compliance committee board of the hospital, and then downstreamed into the selection of the collaborators and the payment methodology and the gain sharing arrangements. So you sort of back up to that point, but this is an excellent point, and I think it's it's one that has to be addressed carefully. And like you said, it can't be exclusively based on volume or value. But I think it does have to be based on, to some degree, up front on those objective criteria. What about, there's a couple of questions here, and actually we've seen it in our practice too about one of the themes in this whole program is care redesign. And I think, Dave, you had talked about it a little bit, how care redesign is a way of, sort of some of the low-lying fruit here of reducing cost. And one of the features of that is the beneficiary engagement and providing beneficiary incentives. And as all the lawyers on the phone know, there's the civil money penalties law prohibits that. But there is a waiver for that. But I think one of the things providers, hospitals, post-acute providers are going to struggle with is, how do you engage in a care redesign program that includes, for example, innovative care redesign, screening techniques, or providing services that are not typically billable to reduce costs and increase quality outcomes, to do those things to produce better results, but at the same time comply with the various waivers that are provided here, which frankly seem kind of narrow. For example, the beneficiary incentive waiver has to be provided directly by the hospital or an agent of the hospital during the episode. That strikes me as being very limited in terms of redesigning. And there's a couple of questions in the box here about innovative programs and dealing with adult daycare and community-based services and things. And I can see that being a really terrific way to reduce costs. But the waivers that are provided under the regulations seem a little bit tight on that. Including the one I just mentioned, and the payment waivers are just limited to the actual payments, not the actual arrangements under which the care redesign occurs. So there's a little sort of a mismatch between the aggressiveness of the bundle payment methodologies and the fraud and abuse laws. But Fred, might I throw that out to you? It's more of a legal comment, and Dave, you can obviously feel free to add anything you have as well.
I think you make a really good point. These waivers are not they're not broad. They can be very specific. For instance, the beneficiary inducement waiver cannot do anything pre-hospitalization. You have a scheduled joint replacement, and you want to get out in the patient's home and look at things, and it really has to be the kind of inducements really have to be occurred during the course of the episode. There's also a limitation on that it has to be provided by the hospital or an agent of the hospital. So I think it will take some creativity in applying those, in looking at the waivers and figuring it out how you comply with them, or if you're outside the waiver, that you're comfortable that you don't have a problem. And Dave, do you have anything to add on those?
Yeah, I'd say I think there are two levels to care redesign that we've seen. One is just working to identify providers in your community and you're caring for the same patients you're caring for who are really eager to embrace this and are willing to collaborate and want to work together to find improvement. And in some cases, the self-motivation for that may be just the eagerness to be in your preferred network and being preferred for referrals in a way that's supported by the regs, which there are ways to do that in these programs. And thinking about that first and finding those providers who do really want to collaborate to drive improvement and work together in the populations that you're working with, and then bringing in Gainsharing down the road. We're seeing a lot of that happen without necessarily having to have the complexity of the Gainsharing agreements and bringing in the waivers, and that's driving a lot of improvement. The reason why I emphasize so much that we do like to see Gainsharing with those surgeons who can really help drive the most improvement is they're just so important to the process, particularly for obviously for patients at CJR and getting major joint replacement. Because we really want to see the process start in the pre-surgical visit, which happens 2 to 4 weeks before the surgery. Chris mentioned what's driving the most improvement. One thing that drives a ton of improvement is how that conversation happens when the surgeon is telling the patient what to expect over the next 3 months as they're going to have this procedure, and where they should expect to go post-surgery, for how long, which providers they should see, getting the surgeon engaged in that process, getting the joint class oriented to that process. All those things happen before surgery, before the patient even gets to the hospital or gets to the admit day. Getting those folks engaged, I think, in having the Gainsharing for that community is, I think, really important. For the rest of the folks, it does get a lot more complicated, and we haven't seen it be necessary to actually get a lot of improvement.
Makes sense. One question we've been seeing kind of repeatedly is, can a hospital enter into a Gainsharing arrangement which is solely based upon efficiency? Or let's just say skewed in favor of efficiency. So in other words, let's just say primarily tied to length, discharge location, SNF versus home health, or the length of stay at either of those locations. And my own view on that is no. I think the way the regs read, so the Gainsharing, at least in part, has to be based on some type of quality metric. It can't be exclusively based on, discharge location or length of stay. Like that slide you had up there, Dave, where you were tracking the percentage of discharges that the various physicians discharged to SNF versus home health, and I can see where that's probably the low-lying fruit in terms of reducing costs, because the discharge to a home health agency is obviously going to be a lot lower, irrespective of the length of stay in a SNF. But my own view on that is on the Gainsharing, it can't be just exclusively tied to that. It has to be tied to some level of quality.
I totally agree with that. Yeah, the regs, I think, are pretty clear on that. You can't stint on care. You can't make broad recommendations. The recommendations, the physician has to be looking at that patient individually. So you absolutely can't have quotas or those types of things. There needs to be a quality element to it. There can be certainly an overall cost, an incentive to reduce the overall cost. That's what this whole program, a lot of what this program is about. But yeah, I can't be sort of saying patients have to stay 7 days, or only 25% of your patients go to SNFs or anything like that. Absolutely, I totally agree with that.
Yep. And another area that we seem to be, I think, Fred, you had pointed out, unlike the ACO regs that don't have this, on the ACO waivers, that there's language in the regs that do allow hospitals to anoint preferred providers. Again, I think it goes back, the hospital has to establish, some objective criteria as to who those would be. But there's always been this fine line, in my view, between patient choice and preferred provider. And the way the regs read, it's permissible for the hospital discharge planning office, for example, to say, yes, post-acute provider XYZ is our preferred provider. They've passed some quality metrics that we have in place for selection, but you're free to choose any home health agency, or post-acute provider that you have a relationship or you want to go to. And obviously, the patient choice trumps that, and then, that cost actually does go into the episode. So other than, walking that fine line, how do hospitals sort of budget for that kind of leakage in the system? I mean, I guess from a legal standpoint, you're permitted to walk that fine line, but I'm not sure how you actually quantify and sort of indirectly actually keep in network as much as possible, consistent with legal requirements, those patients. Is it through these care design programs, Dave, with pre-op reviews and engaging physicians and getting sort of a new care plan that really tightens the care redesign amongst a smaller group of providers?
Yeah. So, what we've talked to you guys about this. We've talked to other regulatory lawyers about this. We've read the regs. The interpretation that the prevailing interpretation, as we understand it, is essentially, I think what you said, Chris. Patients have choice, but hospitals can also make recommendations, and they can have put the top their preferred providers at the top of the list. They can put them in bold. They can make those recommendations, but ultimately the patient gets to decide where they're going to go. In our experience, as I'm sure is similar to many folks on the phone, patients are pretty receptive to what the discharge planning team recommends. And frankly, I think these lists are getting better because now these preferred providers are established on pretty good. We're using very well-established criteria to choose around quality and collaboration and outcomes and things like that. So the criteria are getting more rigid, and the patients and their families seem to pay attention to what the discharge planners recommend. But not all the time, and that's fine. Our focus of these programs is we're not going to fix everything overnight. If we can get 10% improvement in the first year as we're working in these programs, and 10% reduction in readmissions, getting patients home faster, whatever the focus area that we want to improve, that's awesome. 10% is great. I think there's more opportunity than 10%, but if we can just think about how we get 10%, that's pretty good. And we're not going to solve every problem. We're not going to avoid every readmission. We're not going to get every patient to our preferred SNF. But we're seeing by implementing a few things and really focusing on those and trying to do those well, we can get 10 and even up to 17% improvement. And it's still not perfect. There's still a lot of room for improvement, but that's sort of our approach to it.
Yeah, that makes sense. I know we've run way over here. Maybe we'll just take two more. One, I think, is pretty straightforward. Somebody asked a question about an episode that is how to attribute, and I can't read the entire question, but it's essentially what happens with straddle episodes that straddle, a reconciliation period. I saw that question. I'm pretty sure that, and I can confirm this we can do an email or something afterwards, but I'm pretty sure that, like in CJR, a patient wouldn't be in the risk period unless their episode started in Q1 of next year or January of next year. So it's not established based on the discharge date or the episode end date. It's established based on the episode start date. So the first patient that would actually be in could create a downside risk scenario would be admitted on January 1st as the earliest date. I don't know if you guys have any different interpretation of that. But you're actually. For some reason, I can't read the whole question, and I didn't. There were sort of two aspects of it. One of them you answered, and the other one, what happens to an individual episode if it sort of straddles the period, and part of the reg deals with, the average length of stay. If the actual length of the stay during the episode is equal to or greater than the mean, you include the full episode. I'm sorry, the full stay in the episode. If it's less than that, you sort of prorate the number of days. So it wasn't really clear which of those two questions the speaker was asking. The questioner was asking. I think it was what you indicated, and that does make sense to me. And then why don't we just end with this one, Dave? I think you've already answered this, but they want to know where the hospital benchmarking data can be accessed. The ranking for quality with respect to the 3%.
Yeah. So it's all right now. It's all on Medicare Compare. So they're doing it based on HCAHPS and on a something called RSCR, which is a sort of a composite complication rate, and Medicare publishes all that on Medicare Compare. To be honest, I don't think all of it is available yet. It changes obviously over the course of your performance period in CJR, but hospitals can get a sense of where they stand, their latest sort of position on those things through what CMS publishes in Medicare Compare. Unfortunately, for providers who are live in the CJR program, they're not really going to tell you where you stand in the performance period until they reconcile. So it's very hard to kind of track in real time where you stand, but you can look sort of historically what your performances look like and use that as a proxy for where you might want to focus on and trying to improve.
And plus, I think some of the tools you guys have developed so that you can get real time tracking on cost obviously will help. Okay, I think it's quarter past now, so we've actually gone way over. But Dave, thank you so much for participating in the webcast here. And there's some questions here we didn't get to. We'll try to answer those in an email format. But I just want to thank you, Dave, again, and Archway for participating with us in this conference. It was very well attended, and it's an exciting period of time. And we wish everybody good success with this. And with that, I'm going to sign off and wish everybody a nice weekend. Take care.
Yeah, thanks you, Chris. Appreciate it. Take care, folks.
And before everyone signs off, I just wanted to repeat the course code for the CLE credit. There was a comment that it was difficult to hear me before, so I wanted to run that one more time, and you can enter that into the Q&A widget if you were unable to do so before. But just to repeat the CLE code, that code is the number 4, followed by the letters W as in William, O as in ocean, V as in Victor, Z as in 0. That's 4WOVZ. So again, please enter that into the Q&A widget now if you were not able to do so before. So thank you again to all of our attendees for joining us, and to Chris, Fred, and Dave for presenting such a great program today. We hope that you guys enjoyed it, and if you have any questions, feel free to touch base with me directly. Again, if you are applying for CLE, those certificates will be sent via email within the next 8 weeks, if not sooner. But again, please do feel free to follow up with me with any questions. Otherwise, have a great weekend, everyone, and thank you again for joining us.